Hello. Now I will discuss on management of acute liver failure. Specifically, definition of acute liver failure, general advice when we are caring of a patient with acute liver failure, monitoring and the general management of patients with acute liver failure of any cause. To start from definition, acute liver failure in children is defined as biochemical evidence of acute liver injury, mainly less than 8 weeks duration, and there should be no evidence of chronic liver disease and hepatic-based coagulopathy defined as prothrombin time of more than 50 seconds or INR more than 1.5, which is not corrected by vitamin K in the presence of clinical hepatic encephalopathy, or PT greater than 20 seconds or INR greater than 2, regardless of the presence of clinical hepatic encephalopathy. Always, we should have to remember that the patient may not be jaundiced at outset and may appear clinically well despite biochemistry. So we should never look at patient. We should have to monitor biochemically. The patient might be not jaundiced, or it may look like a well child despite having such a level of liver failure. When we came to general advice when caring of a patient with acute liver failure, always do not sedate unless ventilated, and do not give FFP except before transferring a patient between hospitals, before interventional procedures, or if there is active bleeding. Otherwise, no need of giving FFP. Patient with more than grade 1 encephalopathy should be transferred to pediatric intensive care unit. We grade encephalopathy into 4. In grade 1, the patient is irritable, behavioral and sleep disturbance is there. There is reversal of sleep time. In grade 2, there is drowsy, confused, but responds to command. In grade 3, the patient is severely confused or agitated, but response to pain is there. In grade 4, the patient is unarousable and there is no response to pain. When we came to monitoring of any patient having acute liver failure, despite the etiology. The first one is continuous monitoring of pulse oximetry and the cardiac monitoring. And also we should have to hourly monitor the respiratory rate, blood pressure, temperature, fluid balance, and the stage of encephalopathy. Every 2 to 4 hours, we should have to do arterial blood gas if the patient is ventilated. And every 6 to 8 hours, we should have to do clotting screen, PT and INR, and daily CBC, urine output monitoring, renal function test, electrolyte, and the liver function test. When we came to general management, daily vitamin K for 3 days, give ranitidine 1 mg per kg per dose or other proton pump inhibitors or H2 receptor antagonists, or scralfate orally or NH2 if not interally fed. Give lactulose 1 to 2 ml per kg per dose to achieve ball output 3 to 4 times per day, which is loose. And if signs of encephalopathy, you should have to nurse with head elevation up to 10 to 20 degrees. And if encephalopathy progresses to grade 3 or above, the patient requires ventilation and sedation. Acetylcysteine is no longer recommended for non-paracetamol-related acute liver failure in pediatrics, but sometimes adults use for all patients with acute liver failure. This is particularly true in those patients under 2 years of age, except a consultant's opinion. The other is fluid and electrolyte management. Overall, the aim is to maintain circulation volume and avoid fluid overload. We should have to restrict crystalloid fluid to 2/3 of maintenance, unless dehydrated or hypovolemic. We should have to start with 10% and increase as required to keep blood glucose greater than 4.5 millimole per liter. And we should have to maintain urinary output at 0.5 ml per kg per hour. We should have to restrict sodium intake to 0.5 to 1 millimole per kg per day. Even if serum sodium level is low, low serum sodium usually indicates fluid retention, which is a risk for cerebral edema. We should have to correct potassium, calcium, phosphorus, magnesium if levels are low or high. Most of the time the levels are low, so we should have to measure and correct it. The other issues in nutrition, if possible, Enteral nutrition should be maintained with high carbohydrate and a low sodium diet. Avoid protein intake of more than 2 grams per kg per day. NG2 feeding can be used in stable ventilated patients, and if enteral feeding impossible, commence to parenteral nutrition. The other is infection. All patients should be monitored closely for infection, and a broad-spectrum antibiotic should be commenced if infection is suspected clinically. And if herpes simplex infection is suspected, IV acyclovir should be commenced, and if fungal infection is suspected, we should have to start fluconazole. Overall, liver size by palpation. If the liver is shrinking with no general improvement, it is a bad prognostic sign. Acute liver failure can progress rapidly. So if acute liver failure present, a liver transplant center should be involved early in order to arrange early transfer to the center if required. Thank you for watching.